Hello and welcome to the Weatherford College EMS podcast, where education meets experience and textbooks meet the street. This is episode 12, and I'm your host, Tyler Holland, also known as the NIH Man. We've got over here our resident EMS historian, Adam Parish, and the been there, done that career guru, Samantha Grimsley. Today we're kicking off a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So, we are going to be talking about all things sugar.
Yeah, it's all about hypoglycemia in our diabetic patients. And there's not a lot of medications in our toolbox here. I mean, we've got 3, which one isn't even on the table, and that's oral glucose. I mean, take us back to our EMT days.
Yep.
But I think when we think paramedicine, we're thinking 1, Dextrose is number 1, and then 2, Glucagon. I like Glucagon. I think it's a fun drug to give, because who doesn't like shoving some saline into some powder, shaking it up, and feeling like a mixology person, and then drawing back up? You know, a couple of little steps along the way. But even so, you know, Dextrose, it's gone a couple of different ways. We've seen it as D25. We've seen it as D50. We have it here as D10. We even mix it with some of our medications for infusions at D5. So let's talk about the aspects and kind of the background and how it all works as far as the mechanism of action goes with dextrose and glucagon.
Yeah, so pulled straight from the NIH, of course. Glucagon binds to G-protein coupled surface receptors found throughout the body in varying concentrations, specifically targeting the glucagon receptors in the liver, gastrointestinal tract, heart, pancreas, fat, adrenal glands, and kidneys. And this binding activates the adenylate cyclase, which increases cyclic adenosine monophosphate levels, and elevated C-AMP stimulates glycogenesis and glucogenesis, leading to the release of glucose, primarily from liver glycogen stores. That's a mouthful to say, guys, but what you need to get from that is when we give glucagon, a series of actions take place which releases our glucose from our liver stores. Mm-hmm. So knowing that mechanism of action, what if we give this to a malnourished patient?
Nothing may happen.
Yep.
Yeah.
Right?
Yeah,
so,
it's even alcohol users.
Yeah,
Yeah.
absolutely.
Why'd you point at Adam when you said that?
I wasn't, because he was saying malnourished patient. I was just tagging on with him. I wasn't saying anything other than just, I'm going to tag off of what he's saying with the malnourished. Like, hey, include alcohol users in this. I'm not saying anything there. All right, continuing.
Good recovery. Now,
Yeah.
So, yes, they're both right. I mean, if you're on the alcohol grain diet or whatever, you may not have those sugar stores to release. So let's take it, one more step further, right? So we know that it's a hormone that'll cause the liver to secrete glucagon or glucose stores through glycogenesis and all that. So that's cool.
Yeah.
But why not just, start an IV, throw some D10 in there?
Oh, but wouldn't it be great if everybody
All
had
that
amazing
good stuff.
veins?
Oh, yeah, that's right.
And they're diabetic, so the chances of them actually having great vasculature.
Exactly.
Yeah, not real good. So you have to take these things into effect, right? Or into account. So, and the other thing I'd like to add, though, is that we're not just going to take our glucagon, if it's like this or otherwise done, pull it out of here, jam it into somebody's shoulder, right? Administer this drug, and then all of a sudden they wake up and Bob's your uncle, you're done.
No, it is not
Sign
like
here,
dextrose.
press hard, 3 copies, see you later, bye. It's going to take some time, guys. It's going to. I mean, I've given it plenty of times to folks with poor vasculature. Things where they're unconscious. They would be described as being somatic or being in that coma, if you will. and you know that like their sugar's dropping.
Yeah.
And you've got to do something. And you try to stick them a couple of times, and it's just not going
Don't make them a
well.
pincushion.
No. Go ahead, and at that point, just say, all right, we have to get something on board. Now, while we're waiting for it to work, you might want to stick them again or something if you absolutely think you can get something. But this tool is kind of like the SGA of hypoglycemia, right? This is your kind of backup. And one of the reasons why is, we've pushed this narrative of, well, what does this do for us, right? In terms of what we're going to see. It's going to take 20, 30, 40 minutes sometimes.
Yeah, and when you're checking those blood sugars, it's not like you're going to see a jump spike. It's going to be like, oh, we went from 60 to 65, and then we went from 65 to 68. Like, it's very... And we know IM is already slow acting.
Yes.
But you're right. It's not that dramatic... I'm alive.
And not nearly like D10 or back in the day D50, where they just start waking up and they're looking around and all of a sudden they're talking and some of them will fight a little bit. We'll get to that in a minute. But that said, we also need to know that once the liver excretes all of its stores, it's going to want it back.
Yep.
Okay. And so if there are some of y'all that have the experience of going and waking these people up, and a lot of times the medic is going to say, let's eat something. Right?
Mm-hmm.
Well, and there's even my policy is I don't leave until they eat something.
Oh, yes. I have to watch them physically eat more than one bite.
Yeah.
At least half of a sandwich.
Yep.
And it has to be full of carbohydrates.
Absolutely.
Because,
my go-to peanut butter and jelly.
Yeah. And it just, you used to see the people, like, I think back to the Men in Black, where he's like, more sugar, more sugar.
More.
That's only great for so long because the body will take it and metabolize it very quickly. But we know that carbohydrates, they are the energy source. And so that's where we can turn everything into the metabolism needs to build that energy and that drive. And so it's going to give you that oomph.
But the difference is, with the glucagon, that liver is going to be angry once that glucagon has been metabolized. It's going to flip back and it's going to want its stores back. It's going to want to start. So it's going to start pulling all of that glucose and everything back into it because it wants to store that up again as an emergency resource. So what's going to happen is if they don't have anything on board, while D10, they'll burn through it very quickly. It's simple sugar.
Yep.
And that's kind of the point, right? But with glucagon, even though it is a little bit more complex and it will take a little bit longer, still they're going to go back down. They're going to still, regardless of whether
as soon as you're up, you're right back down again.
Yeah, regardless of whether they take their insulin or whatever. That now they're fighting not just the potential insulin overdose or insulin without eating or whatever, but now they're also having to contend with that liver bringing everything back in. So they've got to eat something. I don't leave again until they eat a peanut butter sandwich. Something. And so, so that said, you have to start planning for stuff like that, right?
Yeah.
Now, just because you've administered your glucagon, now do you kick your feet up and just...
Nope.
Well, guess we're going to wait for this thing to kick in.
Nope. It's time to transport. Or you're going to be sitting on scene for some time and some dispatcher is not going to like you very soon.
Well, sure. You can consider transport. You can maybe try for another IV if there's another option that has come back around. You can still give some D10.
Yep.
And I want to kind of transition a little bit towards that because, why then if you say, well, hey, we can just have this tube of basically syrup, which was
yeah, I mean, we were joking
D50, right?
about just putting a thing of sugar on the table and saying, here you go, tape a 60cc syringe to it.
Absolutely. Just pour a bunch of water in it.
Oh, it was the hardest.
Shove it in.
Think about trying to push your syrup or molasses through the tip of a 60cc syringe.
Exactly.
It's like everything in you to push this entire thick solution through.
Well, and not only that, but what would happen a lot of times is we would generally give this D50, and if you were being considerate, you would give half, and you would recheck. Well, some people would start to trend up at that point, some wouldn't. So guess what we did? We pushed the other half. And because we don't really titrate it like that, we leave and all of a sudden 2-3 hours later, they're at 500, right? So now they have the opposite problem that we've just left them with.
Oh, but then you go out there and they're like, well, I gave myself my insulin because my blood sugar was so high, and now we're back to square one all over again. Or their pump is
freaking out. Absolutely. Well, so now we have D10. So the advantage of D10, and D10 has been prolific for the last 10 years or so. We've gotten really, really away from D50s. But D10, we can really titrate that to effect.
Yeah, so let's go back for a second, though, and talk about when we're going to these patients. Because ultimately, I think people get very confused in the whole type 1 versus type 2 diabetics. And, what we need to talk about here is 9 times out of 10, the patients that we are running on are type 1 diabetics. And it is because they either took their insulin, or took is a bad word to say, gave themselves their insulin, and then they didn't eat, or they didn't eat enough for the amount of insulin they gave themselves, or they're sick and they are burning through this insulin or on some kind of medication that's up their metabolism and it's just chewing through it, and they go to bed and it's always 4 o'clock in the morning. They've soaked the bed, family saying they're snoring or something is not right. They're not waking up. It's always the same song and dance. When you get the unconscious, unresponsive, altered mental status patient at 4 o'clock in the morning, the alarm bells are already like, this is going to be a hypoglycemic patient. You should just walk in, you hear the snoring respirations, you look at the pupils, you're like, they're not pinpoint. All right, let's take a sugar. And it's just, there's the AEIOU tips already going off in your head, right? And so we end up checking these patients, and what may be a low for this patient could be 40 for this patient, and they both look identically the same. And every patient's levels are going to be different and what they compensate at. I've had patients be at 20 and still be like, and you're like, how are you even right now?
All the time?
Nope, not doing it. But, these patients are the ones where essentially we give the medication and we see the spike, and then they don't want to go because they know they're going to go to the hospital. The hospital's just going to tell them, you have to be better about your medications. You got to do this. You got to do that. Go follow up with your endocrinologist, have a sandwich, send them home, and they've got this ultimate bill. So they know the song and dance of what happens. And so when we're using our medications, we're having to think about, okay, when we wake them up, what's the game plan? What do they want to do? You're asking family, when's the last time this happened? What do they normally like to do? They like to go to the hospital. They do not like to go to the hospital. Sometimes they wake up very angry because they have no idea what's going on and who are these people in their house and everything of that sort, and their system's been depleted of everything. But at the same time, we've talked about vasculature in these patients, not the best.
No.
And so we're trying for everything because we know that glucagon is not going to work right away. And so our goal is we want to give something that helps bring them back up right away. And so, we're trying, and I always tell people, don't make your patient that pincushion. Don't sit there and stab them over and over and over and over and over. And I've been as far as going in the foot and getting an IV in there. But you have to think about that. The vein that you're choosing to give this medication through has to be stable enough, because the second you lose it, this is a very necrotic medication.
And your patient is diabetic.
And now the healing process of the body is way worse off.
Especially in the feet.
Exactly.
The feet,
9 times out of 10, they're probably missing some toes along the way. And so, when we're giving this medication, and that's always the thing that I do in the lab setting when I'm talking to students, and I'm like, okay, you're giving D10, or if they are giving D50, I'm like, what do you need to be doing every so often? Like, you need to check and make sure your IV is patent. Well, how do you do that? And everybody's always looking at me when you have the bag, and they're like, I don't know how to check for patency with this. It's still running. I'm like, that's great. The site doesn't show anything yet. You can drop it below the heart and look for backflow if you have to. But even still, when I was giving D50 in the field, you'd give about 5 to 10, and then you'd pull back a little bit, and you'd give about 5 to 10 cc's, and you pull back a little bit and look for that blood return to come back. And then, it was such a thick medication. It's like, the stability of that vein has to be there.
Is it hard to push because it's infiltrated, or is it hard to push just because it's D50?
Exactly. And so there's a lot of things that you have to be thinking about that. And you're right. We use the term titrate to effect. I see a lot of people that don't think about the fact that the dose of this is really 1 milligram per kilogram, and how many times do we see fire on scene or paramedics, and they're like over their head squeezing the bejesus out of it. Yeah. I'm like, I gotta get it all in. Can't stop halfway, can't stop, won't stop situation until every drop is in there, and then the patient's like waking up at that point, and you're like, all right, well, could they have maybe woken up about 25 mLs back?
Yeah. And like I said earlier, now they're fighting the hyperglycemic issue. We've, and granted, yes, would we rather them be kind of high? Yes. But we don't have to.
Yeah.
It's not what's good for the patient.
Mm-hmm.
And because we have the ability to recognize those effects and those things, that's what we really need to be utilizing these drugs for.
Yeah, and I think the other aspect of it is we see a lot of people in these days, they have, those automatic sensors that are going off that tell them all these things. Some people are still wearing pumps. And if we're not cautious in telling them, what we've been doing, their body is going to sense, oh my gosh, I have this rush of sugar, and start dumping all this insulin back into them. And now we're just chasing our tail back and forth. And so like Adam was saying, we might get that call back out in a couple of hours later because we're doing this over and over and over and over and over. And I've had those patients where you're like, all right, I was just out here 2 hours ago. And or doing the fight with them. Please eat. I've gotten really good about making myself a sandwich in their kitchen. Not myself, but them. But you know what I'm saying.
One for you, one for me.
You mind if I take on for the road? No, that's unethical. But nonetheless, jamming it up with peanut butter. And they always tell you, I don't want to eat. I don't care. You're going to eat.
Yeah, so, one of the things with glucagon is it tells your brain, I don't want to eat no more. So if you do give that to your patient and they're awake and alert and they want to AMA, just be wary that they might not eat. Their insulin, their sugar might drop again. And once you've depleted those liver stores, you're not going to get the same effect. So if you or another crew goes out to respond to that patient, and it would be especially dangerous for the other crew that had no idea that you gave glucagon, it's not going to do anything for that patient now. And they didn't eat, and they don't have any veins, and now what do we do? Right?
So if glucagon is pretty much stimulating glycogen breakdown, is dextrose just raising the sugar levels of essentially glucose? I mean, it's doing the opposite in a sense. Would you say that, or how would you guys attack that theory?
Yeah, I mean, glucagon, like I said earlier, is that hormone that'll stimulate a process, right? D10's already in the absorbable form.
Yeah.
So and that's why it gets absorbed so quickly, and that's why it's so effective so quickly, is because it is ready to use in a bag.
Yep.
And once we put that in, the one of the reasons why the patient is going to go into, again, what they call a coma, right? They're going to become altered, somnolent, if you will. Is because the brain is the greedy pig in terms of what is utilizing that glucose. It wants the glucose.
Yep.
It's like 60% of the glucose that you have floating around in your body, the brain is going to claim for itself.
Mm-hmm.
And so because of that, we can give this, and as soon as it hits the brain wakes up.
Yep.
It is ready to be absorbed, ready to be utilized, ready to be taken care of, broken down, gone in the cell, etc. So, which leads me to another thing that we need to think about with our hypoglycemics: thiamine.
Oh yes, and I think that comes up when we talk about the hormones and electrolytes here in a little bit in another podcast. But yes, you're right, and we'll get to that point in another one. We talk about a lot about D10, and what I do realize when we're talking about some of these podcasts is we don't really talk about pediatrics. And so a lot of the times our type 1 diabetics are juvenile diabetes. We go out there and their blood sugar is super high because they are not diagnosed yet with type 1 diabetics. And so, you've got, that they've got the excessive thirst, the constant urination, they're lethargic and things like that sort. But then they get on insulin, and maybe they're still learning how to utilize it and what the right way is and everything like that. And so I was looking up some things, and the National Model of EMS Clinical Guidelines says that it suggests that no more than 25% of dextrose should be used in children less than 8 years of old, and you should go to a 12.5% concentration in children less than 1 month. And so we don't usually see a lot of D10 for pediatrics. We used to see the little vials that would come in, almost looking, the little containers, and they were, if you had the big container, you had the 60 cc, and then if you had the smaller ones, and then if you had D25, you may have to cut it in half to get your 12 and a half in a sense, and that was what you're talking about. Like, you don't slam the entire thing, maybe you only give half kind of situation. Mm-hmm. And that's where that percentage would come into play. So something to think about when we're talking about kiddos in that aspect. So I'm sorry, you looked like you had something to say.
Well, just like with any drug, you want to be extra diligent and cautious, right? Just because it's sugar water doesn't mean it's not a drug. We're giving it for a medical reason, and it has its drawbacks. It can be harmful to the patient. So we want to be very cautious when we're giving it. We're not just trying to get the sugar up and go home. So.
Yeah. The other thing that I saw that I thought was very interesting, and I didn't do too much research on it quite yet, but they're starting to bring glucagon out as an IN, so giving it intranasally. It's starting to make its way into the field setting. So I'm curious to see where that's going to go. That's a whole game changer right there. Yeah. An aspect of that, I'd like to see how it metabolizes and if it has a little bit different absorption process. So something to think about maybe coming to your protocols in the next few years is glucagon IN.
Yeah, and there's another couple of things I'd like to just briefly mention too. As we're discussing hypoglycemia, I want to stress the fact that this can look like a couple of different things.
Mm-hmm. Yes.
Right. So these guys, again, this is back to the assessment, back to making sure we've gone through all the steps of looking at our patient, understanding what's happening, and moving on from there. Because, they could look like they're having a stroke.
Ooh.
They could look like, it'd be a shame. I know some guys that are, work out in the middle of nowhere that are an hour plus away from a stroke facility. All of a sudden, they're calling helicopters in for this stuff. And, it'd be a shame to, instead of giving a $5, $10 bag of D10 to wake them up and move on about their lives, to instead billing them for a $30,000 helicopter ride.
You bring up an interesting point, though, on stroke for a second.
Yes.
What happens, Adam, if you do have a patient who's having a stroke and they also have a low blood sugar? Do we know that this could cause some issues in the brain if we're giving too much dextrose? So what do you do here?
Okay, I want to go back to a saying that I have said a couple of times already. Titrate to effect. Okay? We want them to have...
And let it affect.
Yes, we want them to have a relatively normal glucose. But we do not want them to have excessive glucose.
Yeah.
Right? We to achieve this, though, we can't, like Sam was showing us, slam this stuff home, squeezing the bag, any of that stuff. We need to be very careful about it. Mm-hmm. But we need to also go through our steps of assessment. We need to make sure that we know what's happening. Pale, cool, clammy. What about MI?
Yeah.
Mm.
What about I had a guy that, known diabetic. I'd run on 1,000 times before. I find out when I get there that he's got a heart rate of 30. Mm-hmm. Okay, like all these things, But when I saw him, I was like, he's low again. Blah blah blah. No,
not this time.
Not this time.
Well, diabetes predisposes you to so many other medical problems, so you always got to have that in the back of your mind. Like, you show up to the same address for the 10th time this week, and you're just going in there with the D10 already spiked and ready to go, and you don't do a proper assessment. You're doing a great disservice to your patients.
Yep. And then, obviously there's the other side when they're hyperglycemic. Mm-hmm. We have our type 1 and our type 2, right? Our type 2s are, if they're hyperglycemic and they're type 2, and we're talking, and when I say hyperglycemic, I'm not talking about 200 or 300, because some of them kind of live there and that's what they kind of battle on the daily. I'm talking about if they're at like 500 plus, and we really got to treat that. That situation, you also have to be able to recognize that is an emergency situation.
Yeah.
And that is because, even though we don't as in the EMS world, we don't carry insulin generally, okay? But that's what the hospital does. With a type 2 diabetic, they're not going to be responsive to that.
Mm-hmm.
This is HHNK. This is a big, big problem for them. Really, the only thing we can do is give them a ton of fluids, help to dilute some of that out, and then hope that the kidneys don't get so damaged that they can't secrete all of that extra fluid to get rid of that glucose. That's almost the only way to deal with that.
So one of their primary issues when they do reach that point is just going to be severe dehydration. And so giving these fluids is going to help out a lot. It's going to help them pee out all the crap that they need to get rid of. So that's the kind of principal reason why we're giving that.
So I actually came across a very interesting thing on GEMS, and I know we're talking more hypoglycemia, but this has to do with DKA, and it says the 5 major actions of insulin. It drives glucose into the cells, it drives potassium into the cells, it's anabolic, it blocks fat breakdown, and then it blocks the protein breakdown. But then it goes on to say the 5 I's to DKA and HHNK. Infection, infarction, infant on board, indiscretion with diet, and a lack of insulin. I think that's a really cool thing, the 5 I's.
Yeah.
That kind of drives home what might be causing, when we talk about like H's and T's in cardiac arrest, here's your 5 I's to what could be causing DKA or HHNK.
Yeah, absolutely.
That's a cool little thing to go with. I was trying, and I came across this because I was actually looking to see, are we going to maybe see insulin in a pre-hospital setting anytime? We get a lot of patients where you were saying their threshold might be high on our glucometer, and the first thing we're like, okay, well, we're going to give fluids. And in the old time and days, try to dilute the sugar is what we used to tell patients we're going to try. Mm-hmm. Not that you would see a big jump in the field setting, but treating for the dehydration like you guys were talking about. But what are the chances? Because we know it has to be a controlled maneuver, but we're seeing antibiotics make a shift into the pre-hospital setting. So what are the chances of seeing insulin?
Well, I would prefer if insulin never got in the field. It is a dangerous thing to play with, and patients, they take it themselves all the time, and you're going to have clinicians that need insulin as well, and they might be very versed in that topic. But you take somebody that's never played with insulin before and you give it to them. We have a lot of drugs that can kill people, but insulin is particularly dangerous, and communicating the exact dose and everything like that is paramount for the hospital when you drop off. And I just don't think that there would be any great benefits personally for giving insulin in the field. I just think that the risks definitely outweigh the rewards in that situation.
Yeah. And that said, and Tyler's absolutely right. I have the same opinion. I don't want to do it. There are so many different kinds of insulin. Mm-hmm. Long-lasting, fast-acting, whatever, Humalog, Lantus, Novolog, 70/30, like all these different kinds of, and not everybody is going to respond the same way to some of them is not going to do anything for them. And that said, it's kind of the same thing as when we start talking about like Lasix, and why Lasix is kind of going away, is because we don't have the ability to be able to say, okay, what kind of insulin do you need?
Yeah.
What kind of long-term effects is this going to have on the patient? And if we can't really, without a reasonable doubt, show that this is going to positively affect them, then really, what are we doing? One of the reasons why antibiotics is taking off is because we can give a broad spectrum type antibiotic that will start the process of healing much sooner. We know that this gives like a septic patient anywhere from 50 to 70% higher chance by giving those quicker, instead of the hospital having to pull all their stuff and whatever. We've already started the process. Now, is it the best? Probably not, because it's broad spectrum. It kind of does a bunch of things. It attacks a bunch of stuff. It inhibits the future growth. Generally, it's not going to be one of those antibiotics that is going to go after something and actually physically destroy the bacteria. That said, if we can go ahead and stunt that several hours before the hospital does it, there's the better patient outcome, right? With this though, there are so many different options that you give a bunch of insulin to somebody, and yes, we have D10, and yes, we have glucagon and things like that, but we don't want to be, oh well, here's your insulin, oh now we gave too much, that acted too quickly, now here's some D10, and now we don't need to be riding that roller coaster, right?
Yeah,
Again, we're trying to be patient advocates,
right?
We're trying to heal these people, we're trying to put them in a better situation. And just going back and forth does nothing to help them at all.
Yeah. And if that were ever implemented, you would definitely want routine labs, and not just our blood sugar, but we want to check all sorts of other things too, A1C, etc., just to make sure that we're not taking them too much. And, there's just a lot that would go into it. I don't think would make it worthwhile doing.
I started to look at something before my computer decided to think I was a robot, but I wanted to see, we see a lot of these new medications coming out in the field, Ozempic, Mounjaro, all of those, semaglutide, all the things that we're seeing for what isn't so much we're seeing it for the diabetic side of things, we're seeing it more for the weight loss aspect. And I started thinking, okay, what is this going to do in affecting us in the pre-hospital setting for these patients who maybe aren't actually diabetics that are taking this medication, and what might we come across in that sense? Is this going to affect their blood sugar levels? Is it not, because they're not technically diabetic? So how does this really correlate? And I think you'll probably say that you see probably more patients having side effects in the or in the hospital setting than we see in the pre-hospital. But I know, from times past, I had a really bad stomach issue a couple of years ago, and the first thing they asked me was, well, are you on Ozempic or anything of that sort? And that was because they were seeing a lot of issues with, like, gallbladder and whatnot. But the thing that I was going to talk about was that it said that this is like the glucagon. It's like glucagon, in a sense, being injected into them, and the way that the liver is processing and everything of that sort. And you're essentially daily giving yourself a glucagon injection with those kinds of medications, and trying to change the pathology of how your body is responding from pancreas, secreting its sugar and the glycogen and from the liver. What are your guys' take on that?
Well,
yeah, go ahead.
Oh, okay. I was just going to say our bodies are very smart. You got to give, your body some credit. Our bodies know what to do. If you're not chronically ill requiring these medications, then don't take them. That's my personal opinion on it. And messing with that and kind of altering your body's normal way of business, if you will, is going to cause some long-term issues.
Yeah.
Absolutely. What she's talking about is the GLP-1 agonists. And the GLP-1 is that receptor that tells you you're full. Mm-hmm. Right? And these drugs, in the very most simplest terms, they're going to stimulate that receptor site, tell you don't eat. So we're going to see people, and I know I have seen some people that are just, they're pale, they're cool, they're diaphoretic. They're like, I'm not a diabetic, but I started taking this Ozempic or Mounjaro or
whatever else is out there,
or insert name of GLP-1 agonist medication here, right? And it's because they don't eat. They stop eating. They stop, no intake.
Oh, but what did we talk about in the very beginning about malnourished patients?
Exactly. So if they don't have the store, then D10 is going to be your better bet. But these guys, and even those diabetics that are type 2 diabetics that are taking that medicine, they stop eating all the things that have turned them into a type 2 diabetic. And they're hoping,
candy.
Yeah, they're hoping that that's going to lower their blood sugar, and it will. But if they're used to living at 200,
yeah, you're taking their compensatory mechanism at that point,
and you bump them down to like 100 and tell them, get used to it. during that transition period, they may be sitting there at, 120, 130, and you're like, oh, I don't know what's wrong with them. No, it's because that's low for them.
Yeah.
And they're still adjusting to that.
It's a good question to ask. What's your normal blood sugar range? Where do you
Absolutely.
feel normal at?
Right. Or if
Absolutely.
it is a diabetic, and if they do see their doctor, they'll know about what their A1C is.
Yeah.
And if you don't know, so A1C is a 3-month study. It's like an average. And they'll give it to you as like a number. They'll say, oh, mine's an 8, a 9, a 10, a 10 point whatever. And you can even, and I'm not saying you have to necessarily memorize exactly what these numbers correlate to those average blood sugars, but you can look it up really easily.
Yeah.
If you put A1C chart on your phone or whatever and look it up, and if they're like, hey, I'm at like a 9.5 or a 10.5, and you look it up and you're like, that's like 250 or 260 average. Well, yeah, of course. If they're at 120, that's low for them.
Mm-hmm.
Yeah, and they're looking, when you're getting diagnosed as a diabetic, they're not just saying, oh, because you have a high blood sugar, you're a diabetic. Most of the time when they're doing those labs, they have you fasting, first of all.
Yep.
So your blood sugar is actually not really that bad. It ends up being that they see something in your A1C.
Right.
And then you get that trending factor, like, okay, you've hit this for this many times. Now we're going to say blah, blah, blah. Do y'all have anything else that you guys want to add to today's topic?
I think we've hammered diabetes into the ground.
Absolutely. So I think that's a wrap on this episode of the Weather for College EMS podcast. Big thanks for tuning in as we kicked off this topic in pharmacology on hypoglycemic medications, a topic that can feel intimidating, but we promise it gets clear with every call and every repetition. From Tyler, the NIH man, to Adam, the historian, to myself, the been there, done it, field tested perspective, we're here to guide you every step of the way. Stay curious, ask questions, and never stop connecting the dots between the meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not just about knowing those drugs, it's about knowing what they do and how they work. Have a great day, everybody.